Good morning. My name is Kristen Quinn. I'm from Arlington, Virginia, and I am 26 years old. First, I would like to thank the FDA for hosting this hearing. I think the overwhelming interest has already demonstrated that this is a very welcome and long overdue opportunity for the ALS community. You just heard from my mother, who opened your eyes to the unique circumstances of approximately 10% of patients suffering from familial ALS, the genetically inherited form of the disease. I would like to draw your attention to an even smaller subset of the ALS community, the next generation in families afflicted with an ALS gene mutation. ALS has been part of my vernacular since the age of 5, and the timeline of my life is full of cracks marking the occasions where my father sat me down to share bad news, each time related to ALS. I have not yet undergone DNA testing for the SOD1A4V mutation, but I intend to do so. It is a terrifying step that I've been working hard toward preparing for. This is because living in fear of your own body and staring down the oncoming freight train that is ALS can at times be mentally crippling. By the time my mother and her family understood beyond a reasonable doubt that ALS was being passed down through the generations, she was already married with 2 children. And over the years, some cold doctors and counselors have suggested we simply stop reproducing as if it were as easy as turning off a light switch. So the emotional and practical implications of deciding whether to undergo genetic testing at a young age are inextricably woven. A positive test result can take a hard blow at future plans for settling down and starting a family. However, we want desperately to contribute to meaningful research. So my questions to the FDA are, what is the next generation's incentive to brave genetic testing? What sort of reasonable hope can we have for a treatment or cure to make testing worthwhile? And if we test positive for an ALS gene and then take the next step to participate in pre-symptomatic clinical research, where is this data going? Is this data going to be contributed to something meaningful and worth our pain and time, or is it going to just sit in a file somewhere? I was 5 years old when my grandfather's doctor told my mother and her family that there would be a cure within 5 years. And as I grew up, the possibility of developing ALS, it seemed so far away. It was easy to brush off, thinking surely science would have a solution by the time I became an adult. But each March, my little brother and I celebrate our birthdays. My fear grows a little more real, and my hope a little less. When our parents were children, difficult subjects like ALS were kept behind closed doors, my mother said, and there were very few informational resources available. Today, more parents are sharing the family history of ALS with their children, who have access to the infinite resource of the internet and understand and welcome scientific advances such as genetic testing and stem cell research. The next generation's awareness of and participation in the broader ALS community is steadily growing. I invite FDA to look at the research being conducted by Dr. Michael Benatar and his team at the ALS Research Collaboration at the University of Miami as an example of this. The ALS Research Collaboration takes a particular focus on familial ALS and its clinical research studies and trials. This research can only be conducted through the participation of familial ALS patients and the bravery of their family members who submit to genetic testing. I am confident as familial ALS comes out of the shadows and the next generation strives to be more engaged, more teams like Dr. Benatar's will approach the FDA. When they do, please consider that the next generation is a part of the ALS community available to contribute to research long before they develop the disease and can therefore provide a wider scope of knowledge for onset and progression. Consider the possibilities of studying a sibling positive for an ALS gene mutation versus a sibling who is negative. The next generation is an underutilized resource that may hold valuable clues to understanding what causes ALS. And as we all know, understanding the causes is an important step toward developing a treatment or cure. I would also like to address risk-benefit analysis from the next generation's perspective. The best analogy I can draw is when I tell friends about my family's history of ALS, almost always my story is met with one about a strong family history of cancer or heart problems. And of course, I respond politely because every family has experienced its share of heartbreak and illness and death, and it's human nature to empathize. But in reality, ALS is incomparable to almost all other diseases. Those at risk for cancer can commit to routine screenings, and many cancer patients fight with all they have and become survivors. Those at risk for heart disease can take preventative measures through a healthy diet and exercise. There is presently no way to prevent or survive ALS. Lumping ALS into the same category as these diseases when it comes to risk-benefit analysis for clinical trials is a mistake as well. The concept of risk isn't the same for those facing the inevitable. ALS patients have very little to lose, so I urge the FDA to give them more opportunity to leave a meaningful contribution behind, particularly in the case of familial ALS patients who are participating in trials for the next generation in their families. Sadly, my mother's generation may not see a cure, but it would mean the world to them if they could contribute toward one for mine. Should I develop ALS, I hope to participate in any way possible to help reach a cure for my brother, my cousins, and our future children. Beyond that, my family has had the honor of meeting many sporadic ALS patients over the last few years who have looked this disease in the eye and decided to make a difference. These patients, along with their families, raise awareness, raise money for research, and participate in clinical trials, even without the potential for their relatives to develop the disease. They too scoff at the perceived idea of risk with the hope that no other patient and family will have to endure what they have. This demonstrates that the overall ALS community is one that is close-knit and fierce. It stands ready to embrace any opportunity to affect change. With the aid of a more enlightened FDA, this community has the potential to make great strides toward a cure in the years ahead. And I ask you, please don't leave this potential untapped because my family desperately needs a cure. Thank you for your kind attention.
Thank you. Our next speaker is Michelle Farr.
Hi, and thank you for having me. My name is Michelle Farr. My husband is a member of the Farr family, and we are distantly related to the Quinn family back 10 generations. It was our work together where we were able to map our family's 400 years of dealing with ALS. The Farr family was first discovered in Vermont, and it was documented in the 1800s in the New England Journal of Medicine. Some of you neurologists, you recognize the name Farr, the Farr family from Vermont. That's my husband's family line. And I can't give you a number as to how many in the Farr family have died from ALS. One, because I just haven't had the courage to count it. The number is pretty big. Suffice it to say, if we lose about 50% of every generation. We know that the disease affects any family that has ALS, but those with the hereditary form are particularly affected. Financially, families are wiped out from the costs of therapy and caregiving. At any given time, there is at least one person suffering from active ALS, and typically we have multiple family members suffering with ALS in various stages of deterioration. The costs are exorbitant. The commonly accepted figure is $200,000 to $250,000 a year caring for an ALS patient in the advanced stages. And I was once asked by a dear friend, how do families with few resources handle this cost? And I said, well, we don't. They get sick and they die. There is no treatment. So most of the families, develop ALS between 40 and 60 years of age. We've had multiple occurrences where they develop it as early as in their 20s. And with the advances in genetic testing, the next generation is fully aware of the risks they encumber and the timeframes they have to deal with. The issues of genetic testing are pretty complex and pretty complicated, and I applaud all of our work with ALS Association and MDA in helping us with familial ALS and deal with these issues. It is tough because we ask those questions, for my husband, what if I get it? What about our children? Should we even have kids? What do we do when we don't have a job, when I can no longer work? Who's going to hire me? And for the youngsters, who's going to marry me? Who would love this kind of family? So we talked about this and we said, well, there's, I'm former military, and we talked about where's that post-traumatic stress disorder. And I said, it's different for us. We have a chronic traumatic stress disorder. There's a long history of depression, anxiety, and suicide in the family. It's apparent no relief. So we focus on life when we can, and we celebrate every happy moment, but we know it's fleeting in reality, and we often return to the news from the family in Vermont or the family in elsewhere. There's another diagnosis, another person with ALS, another family that's bankrupt, another family that needs surgery, a ventilator tube, another person that needs a handicap van, an assistant technology. Many more are too proud to ask for help, and they suffer in silence. And denial, fear, and pride keep many in the families from asking for help. It's for these reasons that dealing with a hereditary form of ALS is a little bit different than a typical family affected, if there is such a thing. So what can be done? I've visited a lot of researchers and doctors in clinics. I've been up to Boston. I've worked with the Packard Center up at Johns Hopkins, and I think most of the doctors probably know our name, and at least not my face, or have at least monitored me on Twitter excessively. And I recognize the great work being done within each of those institutions. I also recognize that the work is being predominantly done in silos, and it's frustrating. I know there's pocket efforts to share data and information, and I applaud those. And there's some outstanding efforts done by the Packard Center and by NEALS to create a collaborative framework with strong governance and accountability, a term that they've called collaborative science, and it's a term that I've taken to heart because I believe it is in this that we're going to find the treatment and the options and possibly even a cure. So at a community, we're now at this point to eliminate the term competition. No more competition between an association or an organization or a different clinic. It is time to pull together. So the Farr family and all of our families ask for everyone to work together. Whether it's the FDA, research scientists, clinicians, drug developers, clinical trial sponsors, not-for-profit organizations, and our families ourselves, whether we are positive for the genetic mutation, whether we don't know if we have the genetic mutation, whether it's a sporadic condition, we all are stakeholders in this fight, and we want to work with you and for you and be there when we can. And we want to do it in a way that so we can identify and clear those roadblocks. We want to be able to achieve and share analytical insights. We want to share the patient data, whether it's collected on the internet or collected through significant clinical trials and research. Let's look at it and share it. Let's look at it consistent with statutory and regulatory issues, but law is an excuse not to share. Find that path to yes. Hey, yes, we will share. Yes, we will work together. We want to create incentives at a federal level for those activities who are demonstrating and walking that path. Where are those incentives to have people work together? We want agencies and organizations to hold meaningful conferences where the researchers can more openly communicate with the patient-donor community, create task forces and working groups. Please understand that not many of us can travel for either financial or physical reasons, so let's leverage the virtual communities and virtual organizing. You have a wide community right now monitoring on Facebook, on Twitter, and looking at you on webcast, and they are here and they want to help and participate. So use those assistive technologies when we can. And just because somebody cannot speak to you with their voice doesn't mean they don't have a voice at this table and deserve a right to participate. Allow for compassionate use programs and accelerated approval of drugs. Our families want to participate in the learning process. Dennis Myrick, our cousin who passed away a few short months ago, was denied participation in trials. He knew he was positive for the mutation, and he did develop the disease. He lost his mother to the disease, and he has 3 children who are alive currently. He knew he was facing certain death, but he was told that participating in the clinical trials wasn't safe. His wife wanted me to appeal to you and let you know that ALS isn't safe. Death is certain, and the pain is definite. And at least give our families the dignity and the right of participating in the research so that we can play an active part in determining our genetic future. Thank you.
Thank you. Christopher Haynes was scheduled to speak. I understand.